Welcome back to another Diabetes Canada webinar for healthcare providers. This is the third of a three-part series on diabetes and skin conditions, and this webinar is on how we support someone with diabetes and skin conditions. Once again, Lisa Max is here to present, and just quickly, Lisa is a clinical nurse specialist based out of Vancouver and has worked in diabetes for more than 20 years. So I'll pass it over to you, Lisa.
Thank you, Grace. I want to take a moment to acknowledge these beautiful lands that I get to live on. I'm speaking to you today from the Tsawwassen First Nations lands, and I want to thank them for the stewardship of these beautiful lands in British Columbia over the years so that the rest of us are able to enjoy it. So now, as a certified diabetes educator, we want to talk about how we could support someone with diabetes and skin conditions. There are things we can help with, and there are things that possibly we need to refer out for. So we know that skin conditions are common in people with diabetes. We want to reassure them that they're not alone. There are skin conditions that are within the scope of our practice here. So some examples would be neuropathy screening and lipohypertrophy. We can counsel on this, but we need them to know that this is common, they're not alone. When we talk about diabetic foot ulcer prevention, we need to do some testing there. We need to keep an eye on this because up to 50% of people with diabetes, any type of diabetes actually, will develop neuropathy within 10 years of their diagnosis. Glucose control is top on the list on everything. We're trying to preserve blood vessels, trying to preserve nerves, and just keep them healthy over the long term. Annual foot screening has been an issue during the pandemic because there's no hands getting on the feet. They're not being seen in person. So I know that we've moved to partial virtual visits in many cases. Just want to remind you that it really is good to have them come into the office at least once a year for that foot screening test there. Patients with significant neuropathy, they can have no symptoms and they can easily develop the severe foot ulcers. I had a gentleman walk around for a whole day with a house key on a keychain in his shoe and looking for his house key. When he came in, he had an ulcer already started on there. Another one had a toy car put in his shoe by his young son and couldn't feel it. So they often cannot feel when there's an irritation in there because of the neuropathy, and that can be quite dangerous. And we do know that some people will develop severe neuropathic pain from their neuropathy, which is quite unfortunate because the treatment is about 50-50 in success rate. So we've got some guides here on how to take a look at the foot. So the skin, is it dry or calloused, blisters, ulcers? Are the nails kept or are they in rough shape? Are they getting thickened? Who's doing their nails? Is there a deformity that could be an indication of Charcot arthropathy? Footwear, are they coming in sandals in the winter because they can't fit into a regular shoe? Does the footwear fit properly, or are they going 2 sizes up because their foot's swollen? The temperature, is it cool? Is it warm? Those can be indications of problems there. The range of motion, can they flex their ankle? Sensation, do the monofilament test on the 10 sites. Have them look away. And don't say, here, 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 and give them an indication. They need to be completely blinded to whether that's going on or the filament is being touched or not. Asking the questions, do your feet ever feel numb or tingle or burn? Do they feel like insects are crawling on them? And check for pedal pulses. Is there any pulse rate down there? Are the lower extremities red? That can be indicative of poor arterial flow. And erythema, again, more redness there, and it can be an indication of infection or Charcot foot. The great thing is, though, we've got some tools, and the 60-second foot screen tool is available. So this is a great chart. Really encourage you to take a look at this. There's a QR code on the page here where it guides you through how you can talk to a person about their feet and assess, and gives you some suggestions. And if we go deeper into the INLOS 60-second foot screen, there is a really great chart that gives you checklist very quickly that you can walk through, ask the questions, or do the test. And then it gives you the ability to determine the risk for ulceration or amputation on the right side of the page here. So if there's loss of protective sensation, if they have peripheral arterial disease, it will give you a risk level and the urgency to which they need to be referred. And again, a QR code on the page here takes you directly to these supports. So there's a do's and don'ts of foot care. I'm not going to walk through everything on here, but highlight a few of the important ones. And that's just checking their feet every day, using a mirror to see the bottom of their feet if they can't, trimming their nails straight across if they're still able to trim them, which means seeing it, reaching it, dexterity of being able to do that. If they can't, they should be seeing a specialist for that. Making sure that they have good shoes on, and avoiding this extreme cold and heat, especially if they have neuropathy. Really recommending that they don't cut their own corns or calluses or nails if they're thick. I did have one gentleman who was using wire cutters to cut his large toenail, you know, and we don't even know how clean they were. They might have just come from the garden. So so really making sure that we're advising, a lot of people have workarounds at home and advising them of the best practice there. Watching that they don't apply to things that are too hot, like baths, stepping into a bath or electric blanket, not putting lotion between the toes, and walking barefoot are a couple of other highlights on this chart. More supports, all available on the Diabetes Canada website. Really finding a proper shoe fit. And sometimes that isn't going to happen in your mall shoe store. There was a really great store in Hamilton where I moved from, that they were there for 100 years, and they had dedicated shoe specialists who, if you really wanted a good fit, this is where we were sending people to get measured properly and to get the proper shoe. So really be careful where you're going to buy your shoes if you're looking for a fit. And then more supports that you can give to the patient in the form of handouts. I want to talk a little bit about lipohypertrophy, because that's something that we can absolutely help with. And it is a disorder of adipose tissue. It's often related to insulin injections. In fact, pretty much primarily only insulin injections. It can affect insulin absorption and lead to glycemic variations, actually. So what happens is that if we inject GLP-1 or Fragmin or heparin, we're actually not going to have the highest risk of lipohypertrophy, even if you put it into the same spot. But because insulin is a growth hormone, it's shearing it with the needle. So you're doing damage to the tissue when you put that in, and then bathing it in a growth hormone that's going to harden those adipocytes, that fat tissue, and make them into lumpy bumpies. We can often see them or feel them, but I mentioned in the previous module, they could be concave as well. So they could be indentations in the skin where they dimple in. So don't think that they have to be convex coming out. So they could be in the small lumpies. I've seen some that are diffuse, a little more stretched out and striated, but most of them are in the form of lumps. They can or cannot be visually apparent. If you pinch the skin, sometimes they will show. And if you use a gel with that as well, you can see that. There was one gentleman I came across who was using 350 units of insulin a day and had 2 major lipohypertrophies on either side of his belly button. When we moved him off, we decreased the dose by 50% and injected into healthy tissue. And months later, when he called back, he was still on the lower dose of insulin. So really making sure that people, when they move from lipohypertrophy, they may have kept increasing their dose, or we may have increased their dose in response to the lack of glucose control, and that we do need to make sure that we think about reducing that dose when they go into healthy tissue. So what are the risk factors? The longer they use insulin, the more often they use insulin, because they're just making that damage to the skin. The higher the dose of insulin can cause that as well, or repeatedly injecting into the same space. I see here the size of the postage stamp is recommended. One of the things, I know I've given myself an injection for a while, and I can't remember where my last one is, whether it's within a finger width of the next one. So quadrants were very helpful for me. Whatever works for the person who's injecting. Reusing the needles, not recommended, but we do know with the cost of things that people do reuse their needles, really want to limit that reuse. And really not kind of inspecting the sites and just automatically going, it's nighttime, I'm going to pop my basal insulin in, and I'm not looking down to where I'm going, and I'm right-handed or left-handed and I go on that side. So making sure that they're aware that those are possible contributing factors to lipohypertrophy. And so how do we do this? They can be standing or in a supine position on the table. Adequate lighting is helpful, and palpate in a circular sweeping motion. Gel is also helpful as well to slide across. I will say some of them are not palpable or difficult to palpate. Preventing, we mentioned before, rotating the sites, not reusing the needles, making sure that they have a pattern of where they're going to put that injection in the rotating sites. Educating them to avoid their needle reuse as well. So how can we support them, to try to help them with these skin conditions? If they're prescribed corticosteroids, it's going to impact their glucose management most likely. So we need to have tight glucose monitoring and adjustment working along with them. And whether that be that, you don't have the capacity to see them every few days in the clinic or talk to them, giving them the supports for them to be able to self-adjust according to glucose levels is extremely important. Self-management there as well. Also noting that they may need to adjust their activity. So the pool is probably not a great place, or the hot tub when you have open sores or dry skin problems, and any public pool worth its salt has a sign up to say that you can't come in with those. But it's not a good idea to go into these chlorinated or brominated skin, harsh on the skin type scenarios. So maybe recommending using the stationary bike or a pedal or an arm exerciser. Chair yoga is also helpful, especially if they've got painful areas. You don't want them jumping up and down for things. Resistance band exercises, stretching exercises. And if they don't have weights, they could maybe use a tin can of something, can of food that they could move around there as well, or some other lighter weight they can find in their kitchen or their home. So there are ways that they can still have activity, even with the skin conditions, and we just need to help them walk through that. So the key messages are: reassure them that skin issues are common with people with diabetes. They are not alone. For neuropathy, really try to get that monofilament test hands-on at least once a year and refer to a specialist if they've got problems. For the diabetic foot, we've got patient education material for all of this on the website, and we need them to get referred to a specialist for sure. And for lipohypertrophy, assess it, palpate it, advise them to rotate the sites and change the needles, and make sure to adjust that insulin dose if they're moving from repeatedly injecting into lipohypertrophy, which, by the way, doesn't hurt because there's no nerve endings in it. So they love that site. And if they're moving to a healthy area there as well, we need to potentially adjust the dose, and offer the Diabetes Canada patient education material, the FIT guidelines. That's wonderful.